Thank you, Malcolm, very much indeed. So my name is Imogen, and I want to thank Darryl also for inviting me to speak at his conference, which he so nobly organises each year and does a fantastic job. So thank you, Darryl. Unfortunately, you may want to go to another session because I actually can't answer this question terribly well, so I'm sure there are good talks either side of us. But and if we were playing bingo, we would almost get to the whole line across. Because so far, now Deepak, I don't know whether you've got it as well. Yep. Okay, so those who've got your boards out ready to go. I think what is relevant is that this talk has allowed me to reflect, and I actually hope that the next 15 plus few minutes will help you also reflect on your own practice within the intensive care unit, that is if you work there. Because what is important is how we manage the dying is left in the memories of those who walk away out of the door once the death has occurred. And I think we must never underestimate what impact that we have, not only upon the patient, but also the families, their carers, as they walk out on that last day. And this statement obviously re-emphasizes that. So hopefully over the next few minutes I'll be able to set some sort of scene. You've already heard quite a lot already. And perhaps sort of look to how we might measure the patient experience and the families that are surrounding them as they die. And really highlight the concern that I have is that we probably don't measure well enough, or if at all, and what should we do? So how many of you have either been as a patient in the intensive care unit or had a relative in the intensive care unit? Okay. Oh, I have too. And I've been one patient, but only when I was 6 weeks old, so can't remember. So quite a lot of you. And I guess, and then how many of you actually have worked in an intensive care unit? So most of you. Okay. So I would suggest to you, you will know this better, well maybe as well as I do, that when you sort of get wheeled in or have some of your friends, relatives wheeled into intensive care unit, life by definition becomes on a knife edge because we look after the critically unwell. It's incredibly noisy. If you've ever tried to sleep, even as a sort of resident in the intensive care unit, it's not possible because it's so noisy and it's very frenetic. So just imagine as a patient what it must be like, and then you're loaded up with disease, and then you're loaded up with drugs, even worse. And incredibly confusing because no one tells you the same story. I had my husband in intensive care, and honestly, he said to me, "Who's telling the truth?" I said, "Well, don't know really." Believe the intensive care doctor. So it's very confusing. And then, of course, as soon as you get wheeled through intensive care, you lose control. I mean, part of you wants to lose control because you're so sick that actually you just prefer that someone makes those decisions. But it does mean that you are really sometimes losing the control, and including those life and death decisions. So it's an environment which is not easy to work in, and it's particularly not easy when you're trying to look at the things that would be important to patients as they die. So if you look at the domains of quality end-of-life care, you need this sort of sense of spiritual peace. That's very difficult within the intensive care unit. It needs to be relieving their burdens and also strengthening the relationships with the loved ones that are the most important to them. And again, very difficult. If you've worked in an intensive care unit and have visiting hours, it's very difficult to have the loved ones bonding at that moment in time. Now, obviously, many of us over time have opened up the hours, so at least 2 per bed are allowed in, and obviously more as the situation becomes more critical. But it does mean it makes an environment which is not easy to allow, I guess, a good quality and safe death. Because we lose our sense of dignity. I mean, all those tubes rammed up all those various orifices. There's a loss of meaning to life because suddenly you have no purpose. And then you're, of course, a sense of burden to others, not least your family and those are caring for you. So it's a really difficult situation. If you were then to look at, and this was some work done over a decade ago, as to what the 7 key elements of what we should look at in terms of looking at a high-quality end-of-life process. You've heard a little bit about the patient or shared decision-making, so we need to look at how we engage the patient, if they're conscious, and the family, in the decision-making process? How do we bring them in a meaningful way in such a difficult environment? How do we have meaningful communication? I don't know how many of you sat in on family meetings and cringed at the words that have been uttered by the specialist, often from the outside specialist, but there's not to say that inside we have some issues as well. So it's really something that we need to look to. Continuity of care, again, a real challenge when we do sort of 5 days, 7 days, or even a day at a time, and then you walk in as the intensive care specialist, particularly taking over a patient that someone else has made the decision of, we're going to withdraw treatment on this patient today. And I must admit, I have had the situation where, it's 5 o'clock after the footy match, we're now going to withdraw treatment on this patient. And you think, whoa, that's not my decision, but I have to make sure that I carry out that decision. But it's often very hard to continue the same sorts of care that your predecessor has just done. That's not to say that they were wrong, but it just sometimes doesn't sit comfortably. So imagine for the patient if this is oscillating, we are, we're not, and what we're doing in terms of treatment. And then, of course, what emotional support can we provide patients and their families? We often don't have resources. And what symptom management was we sort of instigate, and obviously you've just seen earlier on this afternoon that there are some very good protocols out there, but not always engaged by everyone. And then spiritual support, what access do you have, particularly after hours? And then, of course, the final domain is how do we look after each other as the healthcare professional? Because if you look at the data, certainly we did a survey of 2,500 healthcare professionals, both doctors, nurses, allied health, up to 20% of people who've experienced the dying process as a healthcare professional experience some sort of distress through the dying process. And yet I don't think we ever acknowledge really the burden that's also carried by the healthcare professionals. So these are 7 domains that we really should look to measure. The challenge is, much of that is very hard to measure if you're just literally going towards the notes. Much of this is not documented, and much of this is really felt, and much should be surveyed. So some of the work that I have done with the Australian Commission on Safety and Quality in Healthcare is looking at dying in hospitals. So we looked at 9 hospitals across the nation, and we particularly looked at those that died in the ward and those that died in the intensive care unit. Because what's said is that 60% of us say that we want to die at home, and yet 60% of us die in the acute hospital, which is poorly set up for the dying process. Indeed, the other challenge that we have, of those that do die in the acute hospital, it varies between each hospital, but if you look at these 7 hospitals, it varies how many have had an intensive care experience on their last admission. So they would have died on this admission, and it varies from 19% of patients dying in the intensive care unit to 36% of this hospital's patients are dying in the intensive care unit. So it's actually more than David was suggesting at the beginning. So a lot of patients are having an intensive care experience in Australia as we speak. And the burden that it carries, not only to the patient, the families, but obviously also to the tax dollar as well. I'm not saying this is wrong, I'm just saying this is what is happening. So we have this tussle between what we can do and whether we should do, the sort of fight between allowing patients to die versus acutely caring for them. So what does the dying process look like in the intensive care unit? As I say, they did this 9-hospital study with a group of people from the Commission and the ANU. And we did this study, as I say, on nearly 1,700 patients. Obviously, a proportion, as I just alluded to, were dying in the intensive care unit. And we did this over a 6-month period. And each hospital was going to observe up to 200 patients each. So what we found was that if you look, I've sort of got the 1,700 patients in the first column and then divided intensive care patients into 2. Those that died quickly, that is under 48 hours, and those that died after 48 hours, because we felt that probably those 2 cohorts would look different. The first thing to notice, and I still don't understand this, is that more men are dying in hospital than women. So I don't know when the women start to die, but obviously not dying in hospital. I don't know why. The next issue is that, well, not issue, but statement, is that patients dying in the intensive care unit are younger than those dying on the ward, which I guess is not rocket science. We're obviously gatekeepers. And also more patients who come into the intensive care unit are from home and not a nursing home compared to the ward environment. But at least 50% of our patients who die after 48 hours have had a hospital admission in the preceding 12 months. That is, that they were knowingly sick already, so we knew that they were sort of highly at risk of dying, and we still admitted them. The other thing I think is quite striking, at least for me, is that I must admit, I always felt, patients who died would have a quick death. But it seems to me that those that are dying after 48 hours are not having a quick death. The median length of stay for those dying after 48 hours is 8 days. So there's a lot of patients who are dying after quite a long period of time. And just really a statement of fact. So we talked about the shared decision-making. Is there any evidence of this in the notes? Now, as you can appreciate, we're not very good at writing things in the notes, and definitely not very good at writing quality notes. So to get any kind of information about shared decision-making is virtually impossible, and we have to use surrogate markers. So really, it went down, did we have a resuscitation plan? And unfortunately, you have to assume, which I hate doing, is that patients and families were involved. Now, surprisingly, it seems to me that even though patients were not coming in with an advanced care plan, so less patients admitted to intensive care unit had an advanced care plan, 3% in all, but how many of those patients then had a resuscitation plan? Well, only 80% that was documented in the intensive care unit did they have a resuscitation plan. Again, I suspect what's been happening is there's just nothing documented. But I still find that a bit of an issue that 20% of patients dying after 48 hours haven't got a documented resuscitation plan, let alone whether they were spoken to, the patients were spoken to or not. Again, the other thing, of course, is that the time frame from when the plan was documented to when they died is short. And so again, I would imagine these patients are expected to die, and yet every plan is happening very within a short time frame of their death. I find quite worrying that nearly 20% of those patients who are dying in intensive care unit after 48 hours, their families have had to initiate the conversation. So that's 20% of patients where the family is saying enough is enough, which I actually thought was quite high. Now, we talked about symptom relief, which is always important when you're looking at dying, particularly in the intensive care unit. If we remove tubes, people become very breathless and we need to do something about it. Well, one thing is for sure is that we do not consult the palliative care team. And so very, very rarely does a palliative care doctor or nurse ever get consulted within these hospitals that were reviewed. And so I guess that's for a number of reasons, not least I believe that death probably happens very quickly once we've initiated comfort care. And also the other issue is that the resources of palliative care teams is very limited. So certainly my own intensive care unit, that would be the major issue. You call on a Friday and you're asked to call back on a Monday, which doesn't really work terribly well. So palliative care is not a resource that intensive care uses, rightly or wrongly. The other issue, of course, is that we do initiate comfort care, which is good, but only really in 3/4 of patients that is documented. Now, when I say documented, we were looking for infusions that might suggest that comfort care has been initiated. But only in 3/4 of patients did there seem to be evidence of comfort care. So I don't know what this means, whether 25% are dying with symptoms, which again makes me feel a little uncomfortable. So I think maybe these are things just to reflect upon. The other thing that's happening is that once comfort care has been initiated, there's still a reasonable percentage of patients that are getting medical imaging, blood tests, intravenous antibiotics. Now again, you can argue if they was for symptom relief, then I can understand why they were still continuing. But it's a bit odd, to my mind, that these things are still happening once you've initiated comfort care. And just to highlight, and I guess this is not, may not be unknown to you, but if we just look at the last 48 hours of life, over 95, or nearly 95% of patients are getting some sort of intervention within the intensive care unit. Now, I think that's not surprising, because I think what tends to happen, and certainly my own practice, is that you would have a family conversation, you would initiate comfort care, take the tube out, and very quickly the patient would die. So in that last 48 hours, there's a lot of things that are happening. So that's presumably why we're seeing so many interventions in the last 48 hours of life. Now, spiritual support is one of those 7 domains, and there is some evidence, but not a lot, that we do consult the chaplain and we bring in cultural support. But I wouldn't say we do a lot within the intensive care or within the hospital environment. But again, this may be a documentation failure. So this is really what we can just find within the notes. So in summary, if you were to ask me how do we measure the quality of an intensive care death, there are some survey tools out there. So Darren Hayland has got Can Help. The challenge always, it's a very long survey, and to give these surveys to patients, or I can't give them to patients after they've died, but to the families is probably quite a distressing experience. So I think it is time for us to reflect on how we're looking at measuring the quality of death within the intensive care unit, which is a very difficult environment to start with. And certainly if you're looking at the notes, I don't believe it helps us particularly if you look at those 7 domains which has been highlighted as the critical issues of looking at quality of death. So we may have the Commission, I guess, giving us guidelines how to manage end-of-life care in a quality way. But I think within the intensive care unit, we need as a community to think very long and hard as to whether we really need to start actively looking at the quality of dying much more so, and bring it into routine measures and reflecting on that as well. Because I think, I personally think that the patient experience up until the point that they die, and during that and afterwards, is the family's experience, and what the supports they have had during and after are critically important. Thank you.